Well, thank you so much, Dr. Shaichus Nair, for the presentation. Ladies and gentlemen, we are moving on to the next presentation. For that, let me welcome on stage Dr. Sheila Balakrishnan, Associate Professor, Department of Obstetrics and Gynecology, Government Medical College, Trivandrum. And the topic is all about fertility and pregnancy outcomes after medical or surgical therapy. Let's begin the presentation.
Thank you very much. I know you're all feeling very sleepy after the lunch. I'm feeling sleepy anyway. And most of what I'm going to speak, I think Mala has already talked about, so I'll just run through it. So I've been asked to speak about the fertility options with adenomyosis. So this is something you all know. Adenomyosis is a two-component disease. First, you have the presence of hypertrophic endometrial glands and stroma in the myometrium, and then you have the muscular changes because of the migration of these cells into the myometrium. So, and there are two forms of adenomyosis. The classic form is what we used to see in the later decades of life, usually associated with endometriosis. In younger without endometriosis, in younger women, it can coexist with endometriosis, indicating a common pathogenesis, and it could also be responsible for the implantation failure, which we find associated with endometriosis. So coming to the fertility, adenomyosis and fertility, it is when I was looking at the evidence, it's very difficult to select the best options for adenomyosis because the evidence is also very limited. There is very little evidence to know at what stage implantation is actually, because this is a very progressive disease. So we don't know at what stage implantation is impaired and when to interfere surgically or medically. In the gross cases, yes, but what is the cutoff? Also, treatment options are not well standardized. So how is fertility impaired? There are a lot of mechanisms: abnormal uterotubal gamete and embryo transport and disruption of receptivity of the endometrium, an enlarged uterus, anatomical distortion, and intramural adenoma can all influence sperm migration, embryo transfer, as well as implantation. Myometrial hyperactivity is also observed. Now, reduced endometrial receptivity and impaired decidualization at the molecular level, and there is abnormal function of implantation-associated molecules such as HOXA10, integrins, especially beta-3, and the osteopontins. And the inflammatory response is also more in the endometrium with increased cytokines. So because of all this, we find that fertility is impaired, and this is just a summing up of the same thing. So, and this was a systemic review and meta-analysis in 2014 by Versinelli, where they looked at the outcomes, and they find that in patients with adenomyosis and without adenomyosis, the clinical pregnancy rate was 40% in women with adenomyosis versus 49.8%, 50% without adenomyosis. This is in the meta-analysis. They also looked at the miscarriage rate. Miscarriage was 31.9% in adenomyosis, and in those without adenomyosis, this is 14.1%. SGA babies and preterm labor were also found to be increased in this meta-analysis. Another quite recent meta-analysis, I think not very recent, 2017, again looking at the effect of adenomyosis on IVF outcomes. So they found that the implantation rate, clinical pregnancy rate per cycle as well as per embryo transfer, ongoing pregnancy rate, and the live birth rate among women with adenomyosis was significantly lower than without. As already said, miscarriage rate was more. And when you compare focal versus diffuse adenomyosis, pooled results gave an OR, an odds ratio of 1.36 favoring focal adenomyosis. And it appeared that surgical treatment or medical treatment increased the pregnancy rate. That was just an incidental finding. This is again a recent review, 2021 I think, where they looked at they looked at all the outcomes also. And there were 17 observational studies, and you've had more or less the same things. Lower CPR, higher miscarriage. But in addition, in this meta-analysis, they showed that it was significantly associated with an increased risk of preeclampsia, probably because of the abnormal placentation, preterm delivery, C-section, fetal malpresentations, again probably because of the uterine contractility, SGA, and PPH, which was all confirmed after correcting for age and mode of conception. In conclusion, they conclude that adenomyosis is associated with many negative effects on fertility, spontaneous fertility, and fertility following ART. And it's interesting to note that even without gross adenomyosis, even what we call as stage 0 or junctional zone hyperplasia, so even just having a thickened junctional zone may affect implantation. So this was a prospective study with 152 women who had MRI. They were not actually women with adenomyosis, they just had MRI prior to IVF, and they found that when the junctional zone less than 7 versus more than 7, the pregnancy rates were 63 versus 26%. And when the junctional zone maximum less than 10 versus more than 10, it was 63 versus 14%. So it's such a drastic difference. And they concluded that an increase in junctional zone thickness was significantly correlated with implantation failure. So that is even stage 0. I think the same, sorry. Yeah. So coming to outcomes after medical therapy, already been mentioned, Shaidas has described in detail. Just to have a quick look, the OC pills, you have very ambiguous data regarding fertility following the OC pill. With Dynogest also, most of the data you find is with endometriosis, and less with adenomyosis. It is again questionable data, but we have quite robust data for Mirena and the GnRH agonists. And then you have the newer approaches, the select progesterone receptor modulators, aromatase inhibitors, GnRH antagonists, which is already spoken about. Again, little ambiguous data. So I'm confining myself to, I think, Mirena and Dynogest, as I said, was evaluated mainly in endometriosis, and they found that no studies exactly in adenomyosis. Now that was fertility. I'm talking just about fertility. Now Mirena, Liang and co-workers studied 358 women with adenomyosis who were undergoing IVF. 134 were enrolled in the Mirena group and 224 in the control group. There were higher rates of implantation, clinical pregnancy, and ongoing pregnancy, and all of them was significant, I think. Yes, all of them were significant. So that is with Mirena. So Mirena was used for 6 months. Coming to GnRH agonists, this is what we all do on a day-to-day basis. What is the basis of using agonists? GnRH receptor is found in adenomyotic tissue, and GnRH analogs have a direct anti-proliferative effect within the myometrium. So they reduce the inflammatory response and angiogenesis and induce apoptosis in the tissue, and this may have a favorable effect on implantation. Hence, long-term treatment may have a therapeutic effect on adenomyosis as well as improve ART outcomes. And what we usually do is you can use either an ultra-long protocol for IVF and do a fresh transfer, but the best results, I think most of us would agree, are when you do an ovum pickup followed by long-term GnRH agonists and then FET, a HRT cycle with FET, following long-term agonists, probably 3 to 6 months, at least 3 months. Many studies show better results because you find it improves endometrial receptivity. Yes, I think this was a study which I already quoted, Neo and Park, and here they looked at in this study there were 3 groups of women: the fresh transfer, there was a frozen transfer, fresh with ultra long, and just a fresh transfer with the antagonist cycle. So frozen transfer following the GnRH analogs for at least 2 to 3 months pre-treatment definitely increased the clinical pregnancy rate in adenomyosis. It was 39.5% versus 30% when you did a fresh transfer with an ultra-long protocol, and 25% whether it was just a fresh transfer with an antagonist protocol. So all this they showed a significant difference. Why are frozen cycles better with prolonged GnRH analog use? It's probably because the implantation markers, so like when you give supraphysiological levels of estrogen, when you get supraphysiological levels of estrogen, especially with controlled ovarian stimulation, you find that even in ordinary fresh cycles, you find implantation markers like integrin beta-3 and leukemia inhibiting factor are all reduced. And in addition, you find that the controlled ovarian stimulation, when you give controlled ovarian stimulation after GnRH pre-treatment, that is an agonist cycle, and then you give a COS or an ultra-long, you give an ultra-long or an agonist protocol and then go for stimulation and a fresh cycle, you need a higher dose and a higher duration of stimulation. Whereas when you go for a frozen cycle following GnRH, it is maximum benefit because you have given an antagonist cycle, lower gonadotrophin dose, shorter duration of stimulation, and you get a higher clinical pregnancy rate following your 3 months of GnRH agonist and a frozen embryo transfer. The disadvantage of this study was it was a retrospective study. As I said, very, very few prospective studies and absolutely no RCTs. So this is, I think, something which is in the offing. And the MODA trial, I think the protocol came in the BMJ, where they just started it. They're comparing modified downregulation with a GnRH analog for 6 weeks in one arm. And in the other arm, you would have standard downregulation for 1 week prior to the frozen embryo transfer. They intend to randomize 162 patients over 30 years to detect a 20% difference in clinical pregnancy rate. So probably we will have an answer after this, whether a frozen thawed embryo transfer following a long-term GnRH is better. Coming to the fertility options following surgical therapy, again, just summing it up, complete resection, that is when you have a focal adenomyosis or localized adenomyosis, laparoscopic complete resection, definitely recommended because you do have good outcomes. But when you go for cytoreductive surgery of diffuse adenomyosis, whether it is by laparoscopy or laparotomy, it is a questionable outcome, as we'll see later. Now, type 1 or focal adenomyosis, quite easy to excise, though it may be slightly more difficult than a myoma, usually done laparoscopically. You have the classic technique, you can use the U-shape method, and for safety, you can use overlapping flaps. But you get very good results with a focal adenomyosis. When you go for type 2 or diffuse adenomyosis, again, laparoscopic or open approach, the proponents of the open approach say that suturing is much better, but the layer technique is much better, is what they say, and they claim that rupture is less. Let's look at the evidence. Partial or total excision of adenomyosis can be done. You can have a vertical or a transverse incision or a H-shaped incision in the middle. I'm not going into the details. Mala has already told in detail. In the middle of the uterine wall, do a complete cytoreductive surgery and a final wound closure in at least 2 layers. You can use 3 layers or more, or the 4-petal approach, etc., avoiding any uterine defect. Now, when you suture in several layers using different closure techniques like overlapping the flaps, using double or triple layers, you find that the scar integrity is much more. Usually, a combined medical and surgical approach is used. You do a surgical approach and continue with medical therapy for some time, and then allow her to conceive or go for ART. So this is, I think everyone knows about Osada. This was Osada's, it was an interesting article to read about the surgical approach. And this is, I think, his double flap repair, where the cavity is not open without opening the cavity. And then when he opens the cavity, you can use the triple flap approach or the 4-petal approach. Now coming to the complications of surgery, now definitely what we all think about is rupture uterus in pregnancy. Now it has been suggested that the optimal wall thickness for conception and preventing rupture after cytoreductive surgery is 9 to 15 millimeters. And they say that laparotomy may give better approximation. Avoiding use of energy sources may also be better, but it becomes very difficult at laparoscopy to avoid use of power when it is a diffuse adenomyosis. Now, a systematic review by Tan looking at reproductive outcomes after fertility sparing surgery for both focal and diffuse adenomyosis, 18 studies and 1,396 women with adenomyosis. In focal adenomyosis, the pregnancy rates were quite good, 52%, and miscarriage 21%. In diffuse adenomyosis, pregnancy rates slightly less, very much less, I think, 34% and 21%. Uterine rupture and preterm labor was 6.8% and 4.5% with diffuse adenomyosis. And in focal adenomyosis, as expected, rupture was nil and preterm labor was 10%. So this is a 2018 systematic review. There is some more, yes. And according to this, focal adenomyosis had definitely higher pregnancy rates. The miscarriage rates were more or less the same, whether it's focal or diffuse, but the pregnancy rates were more with focal adenomyosis. Higher incidence of uterine rupture as expected after diffuse adenomyosis. So they concluded that the decision is to be individualized and surgery to be considered only on a case-to-case basis. And they also said that there should have been sufficient chance to conceive spontaneously. This is another very recent 2022, I think, a review article where they looked, it's a very crowded slide, they're just looking at all the available evidence regarding surgical treatment. I'm not everything, all the available evidence. They've given the number of cases, the approach, whether it's laparoscopy or laparotomy, the pregnancy,
childbirth, miscarriage, and uterine rupture. And if you look at the uterine rupture, I think it's a total of 13 cases of uterine rupture. This is what I got. I think someone mentioned 20 cases earlier, but this is what they showed in this systematic review in 2021. And this is to sum up what they have written is pregnancy after various modifications of the surgical treatment of adenomyosis ranges from 17.5 to 72.7%. By the year of 2016, so this came into what they said is 2,365 surgeries were performed according to reports from 19 institutions. 449 pregnancies were confirmed and 80% led to childbirth, including 2 cases of antenatal fetal death. In all, there were 13 cases of uterine rupture, 3.6%. And they conclude that adenomyotomy has proven its worth in the surgery of this disease. From being an experimental operation or what we call a despair intervention, it has become quite a common type of intervention and is increasingly being used today. So, other types of therapy, already mentioned, HIFU. Even though HIFU was originally meant for women who are not going to conceive, I think there are lots of data coming in about HIFU because pregnancies are occurring, spontaneous pregnancies and ART. And of the 60, this was Zhu et al. In 2016, of 68 patients, 54 conceived and 21 delivered. There were no cases of rupture. So it's quite promising and remains to be validated in infertility. Random RCTs are in the offing. UAE is actually at the moment still considered, fertility is considered a contraindication to UAE, even though occasional pregnancies have been reported. So to conclude, adenomyosis has definitely higher rates of implantation failure, recurrent pregnancy loss, and preterm birth. RCTs evaluating the impact of adenomyosis treatment on reproductive outcomes are missing. Surgery definitely alleviates symptoms and has good fertility outcomes, but can increase the risk of rupture. Could be offered to symptomatic women with recurrent implantation failure. Pre-treatment with GnRH analogs prior to natural conception or prior to IVF ICSI is definitely helpful. Antagonist protocol followed by long-term GnRH analogs and frozen embryo transfer would be ideal. And HIFU is also gaining notice as a safe option for those who want to conceive. Thank you.